Well, welcome back to Best of the Day from the 2013 meeting of the American Society of Hematology. I'm talking this evening with Dr. Farhad Ravandi from MD Anderson about acute leukemia. And Farhad, once again, thanks for being here. We're going to go on and talk about some of the novel agents. One of the agents that has really been very interesting the past few years at ASH is what used to be called AC220 and is now Quizartinib, this agent from, I believe, Ambit Bioscience. It's a fairly specific FLT3 inhibitor, and it's well known that patients who have FLT3 with the internal tandem duplication have a seriously worsened prognosis. And your associate, Jorge Cortez, talked about a phase 3 trial using Quizartinib, I believe, in relapsed refractory FLT-positive patients. So tell us a little bit more about this agent and what the data is showing so far.
So Quizartinib is probably the most specific and probably more potent FLT3 inhibitor that has been in clinical development over the last few years. There was a previous study, PACE study, that was a phase 2 trial which used higher doses of Quizartinib or AC220, as you mentioned, in 2 cohorts of patients. One was patients in first relapse, and the other one was patients in second relapse or after failure of allogeneic transplant. Now, that study did show close to 50% what they call composite response rate, which includes not only just CR, but CRI and essentially clearing of the marrow from blasts. Now, the problem that has been sort of like dogging the development of this drug has been the toxicity of QT prolongation, especially that FDA is very much interested in that toxicity. So in this study, the investigators decided to see if lower doses of Quizartinib can be efficacious and could be associated with less QT prolongation. So they actually this was a phase 2 study, and they used 2 dosing schedules, and one was 60 milligrams and the other one was 30 milligrams daily. And the population was again either patients in second relapse or having failed prior allogeneic transplant, and they had to be older than 18. So again, relapse patients. And interestingly, they did see, again, close to about 50% composite response rate. So by reduction of the dose, they did not jeopardize their responses. Exactly the same response rate was seen for both doses, 30 and 60, but about 60% of those who were initially started on 30 had to dose escalate to 60. In terms of QT prolongation, both dosing schedules had a very low incidence of significant grade 3 or 4 QT prolongation. So this does seem that this agent can be used at lower doses, 60 and probably 30, but I personally think 60 is probably going to be the dose. And the reduction in dose has also got another advantage because Quizartinib is also a KIT inhibitor, and when you reduce the dose, you have less KIT inhibition and less myelosuppression.
That's interesting. Well, I was at that session, and I remember someone, I don't know who made the comment, said, I've never had a patient die of Torsades, but I've had lots of people die of FLT3 ITT positive AML.
Yes.
So I think that a certain amount of toxicity, even though it'll definitely have to be monitored, is going to have to be acceptable.
Yes, we have seen this with arsenic trioxide in APL,
Sure.
and obviously that is becoming more and more of an important agent in APL.
Very good. Let's talk a little bit about elderly AML. I know this is something that the leukemia department at MD Anderson has been very interested in, and a lot of patients get low-dose Ara-C. Some get the full standard 7 and 3, but this group as a whole just does not do nearly as well as younger patients. And there was a presentation this year combining low-dose Ara-C with low-dose lenalidomide. And there have been a couple years ago, Ravi Vij from Washington U in St. Louis had a trial of high-dose lenalidomide. I think it was like 50 milligrams.
That's right, yeah.
in AML. So it's an agent that definitely has some activity. And is there a future for this combination in the elderly AML patient?
So this was an interesting study, and actually to me probably the most interesting aspect of it is the fact that they did gene expression profiling, and they actually identified a gene signature that can predict response in the same population, older patients over the age of 70. They did see a significant response rate of about 40%, so that's actually very interesting.
Better than usual, right?
And unfortunately, they did see about 15% mortality, induction mortality. And I asked the question from the investigator, how do you feel about that? And he did mention that this is still a fairly intensive regimen, and they hospitalize their patients to receive this. So, but there's a lot of interesting data in that abstract, and again, the potential for actually predicting who is going to respond is probably one of the major things about that combination.
Very good. I think it'll be interesting to watch and see, because it's certainly an area with a great deal of need. So another agent that I've been watching recently, and first heard about it from Dr. Kantarjian, is sort of a reformulated form of decitabine called SGI-110 from Aztec Pharmaceuticals. And from what I understand, SGI-110 has a significantly longer half-life than decitabine, so hopefully it hits the hypomethylating target much more effectively. Tell us a little bit about this agent and what the studies have demonstrated thus far.
I think the area of epigenetic therapy is expanding because we are also identifying novel genes that may be related to the methylation of leukemic cells, right. IDH1, IDH2, TET2, DNMT3, many of these. And finding a more potent hypomethylating agent would be of a lot of interest, both in myelodysplastic syndrome as well as in AML. And this agent has been designed to, as you mentioned, to give significant demethylation for a longer period. And there was a phase 1 study that Dr. Kantarjian reported in last year's ASH that showed that the drug is active and is, like the other hypomethylating agents, well tolerated. And in fact, as you mentioned, this is a modification of the decitabine molecule. And in this presentation, ASH, it was a phase 2 study, again looking at 2 dosing schedules, 60 milligrams per meter squared versus 90 milligrams per meter squared. The 60 milligrams per meter squared is what Jean-Pierre Issa calls the biologically active dose, which produces the desired hypomethylation or demethylation level. And 90 is just increasing it up to the maximum tolerated dose. And this was a phase 2 study, 2 co-population. One was relapse refractory patients. Second was older untreated AML patients. Now in the relapse refractory setting, they had a response rate of 16% CR, which is quite respectable for a single agent. And the more interesting was the population of older AML untreated, which there were about 40 of them and had about close to 50% CR rate. So again, showing that this is an active agent and could potentially be an important player, even potentially in hypomethylating failures in MDS.
Very good. I think it's going to be interesting to watch that agent as it moves forward, because as you mentioned, there are all these mutated genes have been discovered that are involved in the epigenome. So we'll wait and see. Well, another study I wanted to ask you about also involved decitabine rather than SGI-10, but Gail Robo's had a trial combining decitabine with plerixafor, which I always thought of being used in mobilizing stem cells for transplant.
Yes.
But what was the rationale behind this combination, and what kind of results did they see?
There's a lot of data on the role of microenvironment in protecting leukemic cells from the action of chemotherapy, and the investigators at Washington University have been leaders in combining plerixafor with chemotherapy, again in order to essentially release the leukemic blasts from their hiding places in the microenvironment and make them more susceptible to the action of chemotherapy. And there have been previous reports of this combination with chemotherapy, even in the transplant setting, and with induction form type chemotherapy. So Gail's presentation was using plerixafor in addition to decitabine at the extended 10-day schedule in older AML patients. She showed that there was not dramatic hyperleukocytosis, which is always a concern about mobilizing leukemic cells. And she showed that there was activity, significant activity, and so future studies will show whether this is going to be the way forward. There are other CXCR4 inhibitors that are in development, so again, this is another area that is likely to be very expanded in the future.
Very good. Any unexpected adverse events with the combination?
I do not believe there was anything beyond what you see with decitabine or plerixafor.
Well, we mentioned lenalidomide, and the French GEM group was, GFM group was also looking at combining lenalidomide with intensive chemotherapy. And I mentioned Ravi Vijay's trial. Can lenalidomide at doses of 25 milligrams a day be safely combined with a standard intensive induction?
Yes, so they did this in patients with 5q complex cytogenetics, and many of the patients had very complex cytogenetics, and they...
So this was not just del5q syndrome?
No, this was complex cytogenetics with del5q amongst the abnormalities. And as I mentioned, many of the patients have multiple abnormalities, and they did eventually found a maximum tolerated dose in combination with Ara-C and anthracycline based chemotherapy that could be safely administered, and the duration of response was not significantly prolonged, so that's an area that needs to be worked at in the future trials.
Very good. And then speaking of combining novel agents with chemotherapy, the British also have looked at Quizartinib and combining that with intensive chemotherapy. Yeah. And are they specifically trying to target the FLT3 positive patients, or are they looking at the entire group?
Well, in the study that they reported, Alan Burnett again presented this, they combined it, they essentially was a dose finding study, and to find a dose of Cozaartinib that could safely be combined with Ara-C and daunorubicin. And they did allow all patients, and there is rationale to allow all patients the same way as we talked about dasatinib and being useful both for KIT mutated and KIT overexpression.
Right.
So FLT3 is also overexpressed in many AML cells, and so it potentially is best and most useful for FLT3 mutated patients, but could potentially be useful in other AML patients as well. And so they did find a dose and schedule where they could safely combine Quizartinib with chemotherapy, and I believe Dr. Burnett mentioned that There is a randomized study that is about to start accruing in a few weeks, so we will potentially hear data from that in future ASH meetings.
Next year or the year after. All
Potentially,
right, very good. Well, we'll stop at this point and we'll come back in a few minutes and we'll talk about some of the studies that have been presented in ALL, specifically with the CAR T CD19 cells, because I think this is really an interesting area. Okay. So thanks for watching this segment, and we will be back with you in just a couple minutes.